Archana Kaza. I'm one of the GI faculty. And today I've been asked to talk to you all about celiac disease. So this is going to be the outline of my talk. So we'll go into a little bit on the introduction of celiac, epidemiology, then we'll talk about pathology and pathogenesis of celiac. And then we'll go over the clinical features, and then we'll go over diagnosis, treatment, prognosis, and some of the newer treatments. So the definition of celiac disease. Celiac is defined as malabsorption of nutrients after ingestion of gluten, and it's characterized by villous atrophy of the small intestinal mucosa, and there's prompt clinical and histological improvement following a strict adherence to gluten-free diet. There are other terms for celiac. It's also called celiac sprue or gluten-sensitive enteropathy. So there's a spectrum of disease here in celiac. As you can see here, there's a genetic susceptibility to celiac, and we'll go over this a little bit, and the specific genes that have been implicated in majority, more than 95% of patients, is this HLA DQ2 or DQ8. And then, so there's a spectrum of disease. So on top is a classic celiac disease, where patients present with typical symptoms, have serologies which are positive, and biopsies which are positive for celiac. So that's the classical celiac disease. And then you have atypical celiac disease, where you have some variations of the classical. We'll go over that a little bit. It could range from mild, very mild symptoms. Typical classic celiac usually has diarrhea, malabsorption, but atypical celiac doesn't have to have those typical symptoms. And then there's silent celiac disease and latent disease, which is yet to be diagnosed. So history of celiac. The term sprue was coined in the 18th century, and it's derived from the Dutch word sprue, which means aphthous disease. It was initially named because of the high prevalence of aphthous mouth ulcers in these patients. In 1986, Howell and Associates observed that celiac disease was associated with specific HLA DQ2 haplotypes. So celiac is very common. It's estimated to affect about 1 in 100 individuals in the US. Only about a third of these are diagnosed celiac, and the rest are in the spectrum of disease that we talked about. 2.5 million individuals are undiagnosed, and they are at risk of having long-term health complications. So people who have a first-degree relative with celiac disease, they have a 10-fold increased risk of developing celiac. So the pathology of celiac. So celiac affects the mucosa of the small intestine. It does not affect the submucosa, muscularis, or lamina propria. So it's characterized by a complete absence of villi, and we'll go over pictures, and there's compensatory crypt hyperplasia as a result of it. There's also a lot of other changes that you can see on the mucosa. So you can have leaky tight junctions, which can cause increased intestinal permeability. There's increased intraepithelial lymphocytes, characterized by plasma cells and lymphocytes. And there's also this enterocyte disarray, where you have the loss of polarity of the cells. So normal intestinal mucosa has CD4 cells. In patients with celiac disease, you have CD8 cytotoxic T cells. So this is what it looks like. So here you can see nice villi, finger-like projections here, and here you can see there's blunting of the villi, and there's compensatory crypt. See, these are the crypts here. You can see the crypts here. These are nice and small. The villi are nice and long. Here the villi are atrophied, and you have compensatory hyperplasia seen in the crypts here. And this picture doesn't show it well, but those are the intraepithelial lymphocytes, these blue structures here, and those are the intraepithelial lymphocytes. So these are some of the changes that you see in the mucosa of the small intestine in celiac disease. So this is another picture showing the same thing. So these are the nice finger-like healthy villi, and this is in a patient with celiac. The villi are all blunted, and there's inflammation in here. So there's a classification for celiac disease. It's called the Marsh classification. So it goes from Marsh 1 to 3C. So Marsh 1 is basically normal villi, normal mucosa. These patients have very little malabsorption, very little crypthypoplasia. They may have increased intraepithelial lymphocytes. The important thing is sometimes just having increased intraepithelial lymphocytes does not make it celiac disease. There are a lot of other conditions, and we'll go over them, that can cause the increase in the lymphocytes and the mucosa. What you need is also villus atrophy along with that. So, and then you have Marsh 2, which has a little bit of villus atrophy, again increase in intraepithelial lymphocytes. And then as you can see here, 3A, 3B, 3C. 3C is the worst, where you have complete absence of villi here and marked crypthypoplasia. And this is again the same thing in a table format. So the length of involvement of the small intestine varies in celiac disease. It usually starts in the proximal small bowel, and as the disease gets more severe, it becomes more extensive. So celiac always starts in the duodenum and then progresses to jejunum and ileum. And that's important to know because when we go over the clinical features and the symptoms, that gives you an indication of what kind of malabsorption or what nutrient malabsorption patients can have, depending on which part of the small intestine is involved. Again, like I said, presence of intraepithelial lymphocytes alone is not enough for diagnosis. This can be seen in other conditions like small intestinal bacterial overgrowth. H. pylori infection itself can sometimes cause changes in the duodenum. It can cause increased intraepithelial lymphocytes. And there are other autoimmune diseases which can do that too. So pathogenesis, it's basically this interaction between gluten and this immune, genetic and environmental factors implicated in the pathogenesis of celiac. So role of gluten. Gluten is derived from wheat, barley and rye. Gluten protein is enriched in glutamine and proline, and it's poorly digested in the upper GI tract. Gliadin is a component of the gluten molecule. It's a soluble fraction of gluten that contains most of the toxic components. So this undigested molecule is basically a peptide which is made of 33 amino acids. It remains in the lumen, and we'll go through pictures for this one, and then it passes through the intestinal epithelial barrier and then causes inflammation. So this is a picture showing that. So here you can see that's the gluten peptide derived from the gluten molecule. So this one is the 33 amino acid peptide. It passes through the epithelium either via leaky tight junctions causing increased permeability, or through transcytosis, and then it goes inside. And here the gluten peptide reacts with the tissue transglutaminase in the subepithelial lamina propria. And this increases the antigenicity of the gluten molecule here. And then via HLA-DQ2 and DQ8 on the antigen-presenting cells, it interacts with the CD4 T cell, which in turn leads to activation of the myofibroblasts, leading to mucosal remodeling, villus atrophy, and matrix degradation. And also, there's also interaction with B cell here, which leads to formation of the antibodies, the tissue transglutaminase antibodies. These are in the bloodstream, and this is what these antibodies are the one that we look for in patients with celiac disease. So in addition to that, there's also activation of cytotoxic T lymphocytes also that happens in celiac disease, again by the gliadin molecule here, which in turn leads to epithelial cell killing, apoptosis, and increased permeability. So again, this is the same picture showing that. And we went over this one. So genetic factors in celiac disease. As I talked about, there's association with HLA-DQ2 or DQ8 gene loci. But the thing with HLA-DQ2 and DQ8 is it can be present in a lot of patients who don't have celiac disease. So the genetic test is useful because it has a high negative predictive value. But if it's positive, it doesn't mean much. So it's good to exclude a diagnosis of celiac disease. For example, if you have a patient who has typical symptoms of celiac disease, malabsorption, diarrhea, weight loss, and then patient has biopsies which are kind of inconclusive or suggestive of celiac disease, but you're not sure, then if you do an HLA-DQ2 and if that's negative, then you can be pretty sure that the patient doesn't have celiac disease. But if it's positive, it doesn't really mean much because, like I said, many people, normal people also have positivity. So environmental factors, there's been shown a protective effect of breastfeeding. There's also introduction of gluten in relation to weaning that has also been implicated in celiac. For example, introduction of gluten before 4 months is associated with increased risk. There's also overlap of gluten introduction with breastfeeding, which may be a protective factor in minimizing the risk of celiac disease. Rotavirus infection has been shown to increase celiac disease in children. Campylobacter infection also has been shown to increase celiac in adults. We don't know exactly why, but there could be changes in intestinal permeability causing the gliadin molecule to go in. Role of microbes. So lack of exposure to certain microbes is a hallmark of our modern times, and we hear about a lot of diseases. So there was a study that was done in 2008, which looked at, which was basically lower socioeconomic status and inferior hygienic environment may protect against celiac disease. So basically what they did was they looked at a population in Finland and population in Russia. So different seroprevalence of celiac were found in both of these populations. Geographically, these are very similar areas and very proximate areas which have similar prevalence of HLA-DQ2 and DQ8, but they have major differences in economic development. And they found that the population in Russia had lower prevalence of celiac when compared to that population in Finland. So again, children who were born by elective C-section are at increased risk of developing celiac, whereas those born by emergency C-section are not. Again, they may have had contact with the birth canal, things like that. There seems to be an inverse relationship between H. pylori infection and celiac disease. PPIs and antibiotics have been shown to be associated with increased risk of development of celiac. Again, the important thing with all of these role of microbes that I talked about, they're all associations and not necessarily causations. Clinical features. Childhood presentation is usually the typical symptoms of celiac are at this point mainly seen in children. We hardly see typical symptoms of celiac in adults. But a typical childhood presentation, they have steatorrhea, with or without vomiting and cramping pain. This occurs after weaning when cereals are introduced, usually around 1 to 2 years of age. So you have to consider celiac disease in all children who have failure to thrive and short stature. Anemia is seen in older children. Clinical rickets is uncommon, but it can be seen in Asian children. Many patients, for some reason, do enjoy spontaneous remission in their teenage years. And like we talked about, breastfeeding can delay the onset of symptoms. So adulthood presentation, it is increasingly recognized in adults. Like I said, it is a very common disease, and unless you actively look for it, you'd probably call them as irritable bowel syndrome or functional abdominal pain, etc. So you have to look for the disease. It is being increasingly recognized in adults. The mean age is usually 45 years. Diarrhea is less common in these patients. They can present with all kinds of symptoms, just abdominal pain, sometimes even constipation, sometimes alternating diarrhea and constipation. So many patients present with obesity and a higher BMI. Like I said, some patients can present with constipation. GI features, they can vary widely, and again, this also depends on the extent of involvement of the small intestine. They can have diarrhea, steatorrhea, flatulence, weight loss. Diarrhea is usually episodic. They can have a high fat content in the stool, and usually this is steatorrhea, and they describe their stools as grayish, greasy, floaty stools which are difficult to flush, and they describe oil bubbles in the toilet bowl and things like that. Steatorrhea is not seen in only proximal involvement. It has to be an extensive involvement of the small bowel to have that.
Why is, for adults, many patients will present with obesity and a higher BMI?
So like I said, it depends. So the symptoms depends on the extent of involvement of the celiac. And if it's a typical adult who eats more than what he or she needs, and has very proximal involvement of the duodenum, they're not going to have that much malabsorption. They have the disease, which puts them at risk of complications of the disease, but they have mild symptoms because it's a combination of how much we as a society eat on a day-to-day basis and how much of the extent of involvement. So that's why we rarely see adults with flatulence, weight loss, and things like that. We see them in some patients, but it's not that common. Because I think the diet that we eat on a day-to-day basis more than compensates for whatever you're losing here.
Thank you.
So the weight loss again depends on the severity of disease and the severity of malabsorption. They can present with malaise, fatigue. They can have vague abdominal pain, bloating. Gas and bloating is very, very common. Severe abdominal pain is again uncommon, and then like we talked about in the beginning, they can present with oral ulcers after stomatitis. So what are the different causes of diarrhea in patients with celiac disease? So one is malabsorption. Malabsorption of fat, carbohydrates and proteins, electrolytes and other nutrients that can cause diarrhea. Patients with celiac disease are also have delivery, because of malabsorption, they have excess fat that goes into the colon. That itself can cause diarrhea and bacterial overgrowth. Electrolytes are usually secreted into the lumen of the small bowel, which in turn increases the luminal fluid in an already damaged absorptive surface. So that's another cause for diarrhea. They can have impaired secretion of secretin and CCK, leading to impaired digestion, in turn leading to diarrhea. And again, if the ileum is involved, they can have malabsorption of bile salts, and again then bile salts go into the colon, stimulate water secretion, causing diarrhea. So these are all the different causes of diarrhea in patients with celiac. So like I said before, due to difficulty in distinguishing mild celiac from irritable bowel syndrome, all patients who present with IBS-D, which is diarrhea predominant irritable bowel syndrome, should be considered for celiac testing. So there are a lot of other extraintestinal features that can also be seen with celiac. One of the most common ones is anemia. So if they have proximal small intestinal involvement, they can have impaired folate or iron absorption. In severe cases, they can also have impaired B12 absorption if the ileum is also involved. So patients with celiac can present with, most commonly they present with iron deficiency anemia, but they can also present with folate and B12 deficiencies. Again, because of malabsorption, in severe cases, they can also present with coagulopathy because of impaired absorption of vitamin K. And these patients can present with easy bruising and bleeding. Hyposplenism. This is commonly seen in patients with celiac disease. It's unknown why these patients have hyposplenism, but it does disappear once patients go on a gluten-free diet. Osteopenia. This is again very, very common, and we see that all the time in adults. So more than 70% of untreated celiac patients and about 25%, osteopenia is seen in more than 70%, and osteoporosis is seen in about 25%. Again, there are various reasons for this in patients with celiac. So they can have impaired calcium absorption due to defective calcium transport. They can have vitamin D deficiency, which because of impaired absorption. They can have binding of calcium and magnesium to the unabsorbed fatty acids, forming the insoluble soaps, which are excreted in feces, in turn leading to osteopenia and osteoporosis. They can also have chronic inflammation, which causes increased bone loss by release of inflammatory mediators. So these patients, these are the different reasons why they could have osteopenia and osteoporosis. And patients can present with bone pain, paresthesias, cramps, and frank tetany from hypocalcemia in severe cases. They can also develop secondary hyperparathyroidism, further exacerbating the osteopenia. They can also have neurological features. This is not that common, but we see it every now and then. Progressive limb and gait ataxia is typically described as gluten ataxia. It's believed to be due to immunological damage to the cerebellum, posterior columns of the spinal cord, and peripheral nerves. They can present with muscle weakness, paresthesias, demyelination of the spinal cord, and cerebellar atrophy. It's also associated with epilepsy, mainly in children and young adults. Fertility and gynecological problems is very common in untreated celiac. Amenorrhea occurs in about a third of women of childbearing age. Menarche is often delayed in untreated subjects. Women with untreated celiac disease, they can present with infertility. In fact, if you are in the infertility clinic, when they're doing their workup for infertility, one of the things that they do is check for celiac disease. And they do get pregnant after they go on a gluten-free diet, and So there's a high prevalence of silent celiac disease reported in women with recurrent spontaneous abortions, intrauterine fetal growth retardation, and unfavorable outcomes of pregnancy, underlying the need to test for celiac in all these situations. Physical exam, for the most part, I think, as I told you in the beginning, in adults, they're going to have a normal physical exam. But kids more commonly can present with growth retardation. They can have muscle loss, loosening of the skin folds, severe iron deficiency anemia. They can present with changes in the nails, and that's called chylonychia, where they have like scooped nails. And they can present with clubbing. They can have edema as a result of hypoproteinemia, hypotension, skin pigmentation, dermatitis herpetiformis. This is a very classic skin finding in patients with celiac. It's called dermatitis herpetiformis, and I have a slide on that. Because of all the vitamin deficiencies, they can present with angular stomatitis and angular chelosis. They can present with hepatomegaly. If they have neurological symptoms, they can present with loss of position, vibration sense, and light touch. Hypocalcemia, again, this is severe hypocalcemia, can cause these signs. It's called a Schwostek sign or a Trozer sign. This may be elicited in patients with severe calcium or magnesium depletion. That being said, for the most part, most patients that we see on a day-to-day basis with celiac don't have any of these symptoms and are normal. Moving on to diagnosis. So how do we diagnose celiac disease? Endomysial antibody and TTG is tissue transglutaminase antibody are now used as the initial screen for the disease. Small intestinal biopsies with the help of an upper endoscopy remains the gold standard for diagnosis. So serology is very good for celiac disease. And I think that is one of the reasons that we are diagnosing more celiac nowadays. It's powerful and it's very clinically useful. So what we check is we check an IgA antibody, IgA TTG antibody, and IgA endomysial antibody. We don't do this on a regular basis, but this is what we check, IgA TTG. IgA endomysial antibody has a sensitivity of 90%, specificity of 99, and a reproducibility of 93. As you can see, these are very good numbers for serological tests. And the same thing with TTG. TTG has a sensitivity of 93, specificity of 95, and a reproducibility of 83. There's also IgG versions of the same test available. There's anti-AGA antibody, also IgA and IgG. These are less reliable. The only situation where you would check an AGA antibody would be in kids, because in kids, the TTG can be false negative. So EMA, we rarely check that. It's a very time-consuming test and it's time-dependent. And AGA is the other test that I talked about that's called anti-gliadin antibodies. It's no longer used. It may have an adjunctive role in children less than 2 years of age. So what is the clinical application of the serological test? So if you suspect somebody has celiac disease, so it's useful, so you check for the serological test if you suspect somebody with celiac, but it's also useful to monitor their adherence to a gluten-free diet. Because once they're on a strict gluten-free diet and they're responding well, the TTG actually becomes normal. And it's also potentially could be used as a screening tool. So when you have a low index of suspicion of celiac disease, less than 10%, you check the serological test, you check TTG, and if the TTG is negative, you can just stop there and say patient doesn't have celiac disease if the index of suspicion is low. And you don't need to do an endoscopy or biopsies for those patients unless they have other symptoms. So false negative tests are more likely to occur in very young children, those with mild celiac disease, and of course those with IgA deficiency. Like I said, what we are testing for is this IgA tissue transglutaminase. So if the patient has IgA deficiency, which also happens to be very common in this cohort of people with celiac, so if they have IgA deficiency, even if they have celiac, your test is going to be negative. So we have to check an IgA level on them. So when your index of suspicion is moderate, so you check a TTG, it's positive, then you proceed to small bowel biopsies to confirm celiac disease. Like I said before, the levels of TTG do decrease on a gluten-free diet, usually reach normal within 3 to 12 months. If the levels do not fall, you have to suspect inadvertent gluten ingestion. Selective IgA deficiency is very common, and it's 10 to 15 times more common in patients with celiac. So when you check the TTG, you have to check an IgA level too. And that's what, when we order a celiac serology in our lab, they first check the IgA and then they check the TTG. So we know if the patient is IgA deficient. If the patient is IgA deficient, then your IgA TTG will be negative, and at that point we check for a IgG level instead of the IgA. So if you still suspect celiac in spite of negative serology, you can test for the HLA. And if it is present, then you proceed to small bowel biopsies, or you can proceed to small bowel biopsies directly too. So this is an algorithm going through how to diagnose. So you suspect celiac disease, you check an IgA level, IgA, TTG antibodies, and total IgA. And if it is positive, then you proceed to endoscopy, do duodenal biopsies. If the biopsies are positive, patient has celiac disease. If the biopsies are normal, patient doesn't have celiac disease or could have latent celiac disease. So this one, you have to be a little bit careful, because like I said, the serological test is a very good test. So even if your biopsies are normal, you still suspect celiac disease in these patients. There are some situations where the biopsies can be normal in spite of having a positive serology, because like I said, celiac disease starts in the small bowel and goes progressively down as the severity increases, and it's also a patchy disease. So if you're just taking random biopsies of the small intestine, and you could miss those areas which actually have the disease. So in those situations, you can have a biopsy which looks normal. So if the TTG is negative and they do have a total IgA which is normal, and then you have to see if the patient is high risk for celiac or low risk, and then proceed accordingly. If it's high risk, then you do an endoscopy, do biopsies. If it's low risk, you can tell the patient you don't have celiac disease. If the IgA TTG is negative, but the total IgA level is also negative, this is a patient with IgA deficiency, then you have to check the IgG levels and then proceed with biopsies accordingly. Genetic testing, we talked about 25 to 40% of general population have DQ2 or DQ8. 95% of celiac disease patients have DQ2 or DQ8. So it has a good predictive value, but a positive test doesn't mean much. Endoscopy with small bowel biopsies, this remains the gold standard for diagnosis. So typically we do an endoscopy, go into the duodenum, So first portion of the duodenum, we take 2 biopsies. In the second portion of the duodenum, we typically take 4 biopsies. So you have to take multiple biopsies to make the diagnosis of celiac. If you just take 1 or 2 biopsies, you might miss the disease. So there are various changes that you can see when you look with the camera, the various changes that you can see in the mucosa. You can see scalloping, you can see absence of folds in the duodenum, you can see multiple fissures, mosaic-like appearance of the mucosa. But in some cases, the mucosa can look completely normal, but you should still biopsy if there is a suspicion for celiac disease. So this is a normal endoscopy. This is the second portion of the duodenum. And you can see here, these are the duodenal folds. You can't see the villi, but you can actually see the small projections normally. But in this picture, you can't see the villi clearly. And this is somebody with celiac. And you can see here the scalloping of the mucosal folds here. And here you can see fissuring in between and this cobblestone appearance. So you can see this in patients with celiac on endoscopy. Again, this one also shows the fissuring nicely. You can see the scalloped folds. You can see the first picture had like nice duodenal folds. Here these folds look kind of flattened out. So this is again a pathology picture showing the same thing. So here you have the increased intraepithelial lymphocytes, as you can see here. Of course, the villus blunting is not clearly seen on this one. Again, absence of villi, compensatory crypt hyperplasia, and then increased intraepithelial lymphocytes. And this is normal. So this one, so I won't go over all of this, but I just wanted to show you this slide here because if patients have a negative serological test, but their biopsy still shows findings suggestive of celiac disease, then there are other reasons that they can have the changes on the biopsy, other causes of villus atrophy, which are not celiac. Cow milk protein intolerance in children, post-gastroenteritis, they can have temporary villus atrophy, which goes away over time. Giardia infection, peptic duodenitis, Crohn's disease, small intestinal bacterial overgrowth, eosinophilic gastroenteritis, radiation treatment, tropical sprue can cause the same changes in the mucosa. Severe malnutrition itself can cause that. Small bowel lymphoma, graft versus host disease, hypogammaglobulinemia, and alpha chain disease. So these are other causes of villus atrophy which are not celiac. So you can check a fecal fat analysis on the stool test. You can check for iron deficiency anemia. You can check iron levels, folate levels, B12 levels. Peripheral blood smear, I don't know if you've had your hematology, but peripheral blood smear can show these classic findings of Hobel-Jolly bodies, target cells, and Heinz bodies. These are findings of hyposplenism, basically. Patients can have elevated LFTs, and if they get any abdominal imaging, BAM small bowel follow through or a CT, you can see thickening of the small bowel mucosa, and they can show some splenic atrophy. Bone scans can show diffuse demineralization of the bones. So these are the different differential diagnoses in patients with celiac. So basically, any cause for diarrhea and any cause for malabsorption is in the differential diagnosis. Pancreatic insufficiency, SIBO is small intestinal bacterial overgrowth. There's a condition called microscopic colitis, which is basically microscopic inflammation in the colon. Whipple's disease, MAC or MAI, Mycobacterium avium intercellular infection in patients with HIV, Giardia infection, milk protein, soy protein intolerance. In rare cases, collagenous sprue. The patients initially have diagnosis and biopsies consistent with celiac, but they don't respond to a gluten-free diet. And then over time, they're noted to have progressive collagen deposition in their mucosa. So that's a condition called collagenous sprue. It's a very hard to treat condition. And you initially start off the treatment like celiac, but they ended up on multiple anti-inflammatories, anti-TNF medications, and things like that. And sometimes they are dependent on TPN in severe cases of malabsorption. So there are diseases associated with celiac. One of the classic ones, and might be important even for your birds, is this condition called dermatitis herpetiformis. It's a skin condition that is very classically associated with celiac disease. It's a papillovascular lesions on the extensor aspects of extremities, buttocks, trunk, neck, and scalp. It's seen in adults, not usually seen in children. It's characterized by speckled IgA deposits in the perilesional skin. About 10% of patients with celiac disease have dermatitis herpetiformis, and the treatment for that, as with anything in celiac, is first gluten-free diet and dapsone. So that's what this looks like. For example, if they ask you a question where they have typical symptoms of malabsorption, a patient has iron deficiency anemia, and then they say small intestinal biopsy shows, or even if they don't give a small intestinal biopsy, they say this has to be showing some flattening of the villi, and then they show you this picture, you have to think of celiac disease and somebody like that. So autoimmune diseases, diabetes and hypothyroidism are also associated with celiac disease, and specifically type 1 diabetes. And this is also a very important association, and we see that time to time in our clinics. Down syndrome and patients with Turner syndrome have increased risk of celiac disease. Treatment, first, second, third, fourth, fifth is gluten-free diet. So you want to avoid all foods containing wheat, rye, and barley gluten. Initially, it is recommended that you avoid oats, and then once your mucosa starts recovering, you can go back on the oats. Usually you use rice, corn, maize, buckwheat, millet, and these other grains, quinoa, sorghum, potato, soybean, tapioca, bean and nut flours are okay. Any wheat products and wheat starch can be used only if they contain less than 20 parts per million gluten. So that's what the guidelines use. So they check for gluten levels, and if it's less than 20 parts per million, it's labeled as gluten-free. And I didn't talk much about gluten sensitivity as opposed to celiac disease, and those are very different entities. Gluten sensitivity is basically a condition where you don't have celiac, so you don't have any small changes in your small intestine, you don't have positive serology tests, but you have symptoms when you consume products with gluten, and that's what we see commonly. And that's different. That basically patients have abdominal pain, abdominal bloating, sometimes diarrhea, and that's gluten sensitivity. And it's very, very important to distinguish, especially nowadays when you have somebody with newly diagnosed celiac disease. It's very important for them to understand the difference. Because for patients with celiac disease, for patients with gluten sensitivity, even if they consume a little bit of gluten, they're just going to have symptoms. They won't have any damage to the mucosa. Whereas a patient with celiac, if they consume gluten, in addition to symptoms, they have all these changes in the mucosa, and we'll talk about that. Untreated celiac disease does put them at risk for small intestinal cancers. So it's important for the patients with celiac to understand that. They're not like a typical gluten-sensitive patient. They actually will have changes, ongoing changes in the mucosa in response to gluten. And that's very, very important distinction. So basically you have to teach these patients to read all the labels properly. And there are a lot of hidden sources of gluten. You have to be aware of gluten in medications, supplements, food additives, emulsifiers, stabilizers. Initially, patients with untreated celiac disease also have lactose intolerance, but once the mucosa recovers, they can start consuming milk products. Beers, lagers, ales, and stouts, all of these also are sources of gluten, so they have to be aware of that. So these are some of the potential hidden sources of gluten. Like I talked about, beers, the fermented beverages, candy, communion wafers, drink mixes, gravy sauces, herbal teas, imitation meat and seafood, lipsticks and lip balm, medications, Play-Doh for kids, salad dressings and marinades, self-basting turkeys, soy sauce, and toothpaste. So all of these are potential hidden sources of gluten, and unless they have a good education on these, it's hard to know if we're consuming those. Right? So key elements in management of the patient is consultation with the skilled dietitian. They have to know about gluten, celiac disease, and they have to know about all their hidden sources. There's also a lot of support groups. Pretty much, I think every place has their own support group. And same thing in Albuquerque, there are some support groups which are available for celiac. Educate them about the disease, educate the importance of adherence to a gluten-free diet, and you have to identify and treat any nutritional deficiencies. And long-term follow-up, at least you want to see these patients once a year. So untreated celiac patients can have damage to the surface epithelium and can have lactase deficiency. So initially they're supposed to avoid milk. And like I said, after their villi recover, they can start consuming milk products. So dietary supplements, you check for these deficiencies and you supplement them. Iron, B12, folate. You check for vitamin K, check an INR, which is an indirect measurement of vitamin K, and those with easy bruising, you have to supplement that. Patients with dehydration, give them IV fluids, supplement calcium and vitamin D. And this is important because they have to, after 1 year of gluten-free diet, they can reverse their osteopenia. Bone mineral density should be measured 1 year after diagnosis of celiac. And you also want to put these patients on multivitamins initially till their mucosa recovers. So there's an entity called non-responsive celiac disease. So these are patients who have persistent symptoms and lab abnormalities despite adherence to a gluten-free diet for 6 months. First step when somebody comes with that is you have to check and see if the initial diagnosis of celiac disease was correct in the first place. Second thing you want to check is see if they have any hidden sources of gluten. And then if you rule out those things, then you can look for other things. And these are some of the other things that you can see in patients with celiac. They are at increased risk of having small intestinal bacterial overgrowth, pancreatic insufficiency, microscopic colitis. They can have IBS on top of celiac, and that's also very common. We see a lot of IBS on top of celiac. They can lactose and fructose intolerance, any parasitic infections, and lastly malignancies. This is very important because patients with celiac are at increased risk of having small bowel lymphomas and small bowel adenocarcinomas. So you have to think about that when patients present with persistent symptoms. So overall prognosis of celiac disease is excellent if it's diagnosed early and patients are on a strict gluten-free diet. Children who go on a gluten-free diet have normal growth and development. Osteoporosis, secondary hyperparathyroidism, peripheral neuropathy, and ataxia may not be reversible on a gluten-free diet. Osteopenia is reversible, but once it gets to osteoporosis, it's harder. There are a lot of other newer treatments which are being studied as alternatives to gluten-free diet. For example, there are these oral glutenases. These are the enzymes that cleave gliadin in the stomach and small intestine, thereby avoiding the toxicity from the gluten. As I mentioned, celiac is associated with increased permeability. So there are these this medication called larazotide is being studied, which inhibits the paracellular permeability. In early trials, it's shown some promise in reversing signs and symptoms of celiac. Genetic wheat modification is also being studied. Inhibitors of TTG are being studied, and IL-15 blockade is also an attractive possibility for celiac disease. So these are just potential future treatments which are currently being studied just in a picture form. So in summary, celiac is a very, very common disease. It has a prevalence of 1%. So you have to have a high index of suspicion and look for it. They can have varied clinical presentation. Diagnosis, initially start with serological tests. Gold standard is upper endoscopy with small intestinal biopsies. And the key elements are your gluten-free diet is an excellent treatment, but look for any hidden sources of gluten, access to a support group, and a nutritionist long-term is very important. And that's all I have.